truly a privilege to gather here today. Such a diverse and dedicated group who share a common goal that is translating research into impactful health solutions. I am Dr. Ashu Grover, Head of the Division of Implementation Research at ICMR New Delhi, India, and I warmly welcome you all to this webinar on implementation research. The primary reason for conducting this webinar is to enhance the knowledge of health researchers in the field of implementation science. Recently, ICMR has been emphasizing the need to undertake implementation research to translate proven, effective, and customized interventions into action to improve public health outcomes. In this regard, the division has initiated a series of webinars to foster a better understanding in this field. During this webinar, there will be certain questions which can be posted in the chat box. The relevant questions will be answered at the end of the session. Without further ado, I would like to introduce our first speaker in this series, a distinguished leader in public health and maternal and child health research, Dr. Rajiv Bahl. Dr. Bahl began his career as a scientist at AIIMS, New Delhi in 1993 and progressed to become the head of the research on maternal, newborn, child and adolescent health research at World Health Organization from 2013 to 2022. Dr. Bahl is a respected physician scientist, currently serving as the Secretary to the Government of India in the Department of Health Research and Director General ICMR under Ministry of Health and Family Welfare. With over 30 years of experience, Dr. Bahl has a rich history of research and has excelled in leading health research initiatives and translating evidence into impactful public health policies both in India and globally. Please join me in welcoming Dr. Rajiv Bahl to share his insights and experiences with us today.
Thank you very much, Dr. Ashu Grover, for that very kind introduction. The purpose of talking to all of you today is to talk about and to share my understanding of what I have learned about implementation research. If you could just load the presentation and share the presentation. I hope people can see the presentation. Dr. Kavita, is it visible?
Yes, sir. Yes, sir. Please go ahead, sir.
Okay, thank you. So this is kind of the summary of what I have learned about implementation research in the past 15 years or so. Compared to other branches of research, implementation research is not too old. At least my foray into implementation research started when I joined, or we created in the World Health Organization, a 4-department consortium on implementation research, which included tropical disease research or TDR, reproductive health research unit of WHO, the Alliance for Health Systems and Policy Research, and my department of maternal, newborn, child and adolescent health. And there, although IR was being conducted earlier, but I was not to the center of these things. But since then, I, for about 10 years, supported technically and financially many implementation research initiatives in WHO. So I will talk to you and share my thoughts of what I have learned. Next. So the best definition I have found is basically given by TDR WHO. And it basically says that implementation research is a systematic approach to understanding and addressing barriers to effective and quality implementation of health intervention. So we need to understand that most people think that research is about finding completely new knowledge, which is like discovering new knowledge. It is a very important part of research. Basic understanding of new things. We heard the other day, there was a public lecture on by a Nobel laureate in NII who has worked on T cells and found fundamental things about T cells that led to development of newer therapies. So yeah, that is great research. There is no doubt about that. There is also then converting that new knowledge or discovery to actually development, which he did. He worked to develop a monoclonal antibody that would actually stop something that was preventing the body's T cells to kill cancer. And when they did that, they had to do clinical trials. They had to innovate. They had to develop the product, and they had to do clinical trials. So people think that is also research. Yeah, sure. Some clinical research is important. So development research is important. Clinical research is important. But many people think that what is there in implementation research? Okay, you are basically implementing something. The research is in making the approach systematic for both understanding and addressing what is stopping good quality implementation. If we were able to implement what we know and the interventions we have, we would improve health of all of the people of the world several fold. In our country, there is no doubt that our biggest problem is that our whatever we implement is implemented at 30%, 20%, 40% efficiency. Any program, when you start looking into coverage and quality, Anemia Mukt Bharat, okay, there are 6 strategies. I look into one of them and I say, okay, adolescents, yes, great program. We reach them, we treat, we screen, we do. How many people were we giving prophylaxis? Total number of children in adolescent. Yeah, all schools, this. When you count, doesn't count over 20% of all children in the country that are expected. When you look at screen, 2%, 3%, 5%, where you are actually able to screen everybody. With the exception of pregnant women, none of the others are reachable. Then what is the point of making a policy if you cannot implement it? So learning where are the pitfalls, where are the difficulties, addressing them and solving those problems. That is the key to implementation research. Why is this not? I don't like to use the word action, operation. Never words have been used before. I like implementation research a little bit more than other words. The reason is it's very clear. We are trying to research how to implement rather than some of the others that we have used. Also, that next slide, please. So again, the WHO definition, if you go ahead, it says identify, breaks down into identification of common problems, their determinants, which prevent effective access to healthcare. Or 2 words, effective access, means to me good quality, good coverage, and people are able to get what the healthcare we want to give them. So understanding not only the problem, but also what is causing the problem, the determinant of the problem. But many times when I was at WHO and we ran these implementation research calls, half of the project stopped at just that. They said, we will tell you what are the problems, and then the problems can be sorted by the program. What is our issue? We will analyze, we will tell you. I don't think that it is the right approach, because IR should go through all of these three steps rather than stopping short at the first step. Because we usually in one call we had this and we eventually said we need the entire pathway. This is step one in the pathway. The second step is develop practical solutions to those problems, which come from local knowledge, which come from context, whichever context. So you must do these in multiple contexts if you want to generalize something. Because generalizability of implementation research is only possible if we have tested it in at least a few contexts, if not many contexts. But you develop practical solutions to those problems and test those solutions. That do they actually change that access to care? Please note that we are not talking about changing outcomes. We are not talking about health outcomes. We are talking about changing access to effective access to healthcare. I would convert this into coverage with quality. Getting coverage easily is not about I have a health facility here, so that is the coverage. I look at coverage from people's perspective. People who need to get a particular health care, what proportion of them are getting the, for example, vaccination coverage. Vaccination coverage is not that we have the vaccine or we will give the vaccine or vaccine is available. Vaccination coverage is that children, we know that all children need to get the vaccine. What proportion of them got the vaccine? And whether it was done with quality. Did we give them expired vaccine? Did we give them vaccine that was not maintained in the cold chain? Then that's not useful. So vaccination coverage with quality. Quality vaccine, which was given to them in effective cold chain, was maintained. Appropriate dose was given in an appropriate way. That is quality coverage, your effective coverage or effective access to healthcare. And the solutions must lead to that, at least. If we don't need to show necessarily that they will then change health outcomes. If you do that, that's a bonus, but you don't need to. The last part is that then you make implementation strategy and put it into the program at scale and test them at scale. Modify if they need to be modified, because at scale what you have developed may or may not be working. So unless you do these things, I would not consider it complete implementation research. Next. Now, what is the difference? There are some differences between the standard effectiveness research that most researchers are used to. This is the way we all think. And this was another area that we saw global calls were made on implementation research. People's thinking was like effectiveness research. The thinking was not on implementation. And I'll tell you what this thinking is. In the thinking, there is a health intervention, which means, let's say, a particular treatment for a disease is a health intervention. A preventive strategy is a health intervention. So there is a series or single or multiple interventions, and we try to implement them, and then we try to look at the impact on some outcomes like mortality, morbidity, growth, development in children, etc., disability. But this thinking is ingrained in our mind. It is the RCT type thinking. And you have an intervention, you have a comparator, you give it to both the groups, you look at the outcome. And then you say it works or it does not work. That is the outcome, or it works in 40%. It has 10% impact on mortality, it has 15% impact on morbidity, etc. In the middle, we try to do a few things, some process evaluation, a little bit. What was the but very little. In a 3,000 word article, process evaluation may be a small paragraph. Describe how interventions were implemented, what was their cost. Usually we don't even do that. There is no description. Oh, we did something that it was implemented by many people, but not detail of how intervention, but very brief. Usually even their cost is unknown. Many times people don't even show the coverage or the quality of the intervention, just the impact. But they may show a table in between. What was the percentage of people who received the intervention? What was the quality of that? Usually good papers will get those. Good papers will have all those four things, but they will be in brief. And the main result will be the impact on or the outcome being some health outcome, death, disability, morbidity, growth, development, etc. Next. In implementation research, it is slightly different according to this is just a schema that I have made for my thinking and my understanding. That we have strategies that address implementation problems and allow scale up of those interventions. So these are things that are strategies to surmount the problems of implementation. And what we will measure is high coverage and quality of health interventions, whether we can achieve high coverage and high quality or high coverage with quality of health interventions, but at scale. And the corollary is I don't want to do implementation research on anything that I don't have data on efficacy or effectiveness, which means I must know that it works. The only problem that we are trying to solve is delivering it at scale, making it go reach the implementation problems to make it go to scale. So anybody who proposes implementation research without showing me unambiguous efficacy or effectiveness data, I don't even consider that it should be thought of, done, or funded. Because the outcome of implementation research is just solving the problems of implementation. In this case, what are the outputs of research? The output of research is not that you achieved high coverage. The output of research is that how did you achieve high coverage? What was that implementation strategy or model that you used? How was it different from that the model that is currently was earlier being used? That is the major research. The second research output is, okay, I have this model, but what was required? How many people did you need? What were inputs? What kind of funding did you require? What kind of budget did you have to use? What kind of, so both men, money, material. Usually we say human power, then we need to have some infrastructure, equipment, etc. that was required, and the financing that was required, without which any implementation research has no meaning. So this is what you want to know. How did we get it? And then what was the process? Yes, inputs were okay, but what process did we follow? How did we train? How did we monitor? How did we do something? Were there tools that we used? You put all those in public domain and say, these are my research outputs. Now, when I see implementation research papers, sometimes people just say that we conducted this implementation research and our conclusion is it is feasible. It is feasible to control hypertension in India. Excellent. Good. But it doesn't help me. Doesn't tell me anything. What I want to know is, how did you do it? Not just very briefly, but in detail. What were the inputs? What were the people? What were the infrastructure, equipment, drugs? What was the cost? What were the processes that you used so that I can replicate? If you don't give me that, I can't replicate. So my output of research is not a number, not that this study was done, 40% people received the intervention or achieved some coverage of treatment. Not interesting. What I want to know here is, how did you do it? Next. Now, when we look at what is called the consolidated framework for implementation research. So how do you think about these issues, problems? What do you see? So there are these many frameworks which you can use. What I have used, and mostly people have used, is this consolidated, where they have put together many and then have come with whatever many people have said. So this is most often I have used this. It has these 5 boxes. One is called the outer setting, the one in red, the outer setting. But let's start from inside. So first thing is, what is it that you want to deliver? What is it that you want to implement? Usually these are health interventions. So what are their characteristics? What is that? What is that you want to, unless you have clarity on what you want to deliver or scale up? What is this Anemia Mukt Bharat strategy? Is it clear, unambiguous, without problem? You know exactly what it means, what is supposed to deliver to everybody. So I'll give you this example. Kangaroo mother care or immediate KMC for that matter. But first, let me explain the circles. So the yellow circle is what has to be implemented. The immediate next circle is called the inner setting. I call it the health system context. People who will be delivering those interventions or promoting those interventions or taking those interventions forward. So those are the inner setting. So it is basically the health system. What are its issues in implementing that? That is what you want to understand and correct. The next one is the process of implementation. Well, okay, I'll come to the process later. Let me first go to characteristics of individuals. So then these are the players. Who is getting the intervention? Who needs to get? So there is a demand side and there is a supply side. The light blue circle is the supply side, but the darker blue is the demand side. What do they want? How do they see this intervention? How does this work? So both sides have to be looked at. But then there is something called the outer circle, outer setting, which means these things are not happening in a vacuum. It is happening within the context of the society, within the context of politics, society, norms, the milieu in which all this is happening. The outer setting is the broader context, political, social, societal, etc. Now, all that on the one side, then we need the process. That how will we do this? How will we connect, take that intervention, connect the supply and the demand, considering the outer circle, how will that process work? So I'll give you this example of immediate KMC. Now, what is immediate KMC? Actually, we had a webinar a few hours ago on immediate KMC, why we want to do it. Forget that. Say that it is kangaroo mother care started immediately after birth. It is not implemented today anywhere or is implemented only in a few places. If we want to learn how to scale it up, was a project that we designed in WHO. It is still ongoing as of today, but how did we think about it? So we said, now let me start from the outer circle, that there is a broader thing about how do people, what is the policies and resources around sick and small newborn care? What is the general availability of resource for this? How much is the political will for reducing neonatal mortality? What are the societal norms around babies? People think क्या एक बच्चा ठीक है होता रहता है कुछ ना कुछ बच्चे तो मर दिए जाते हैं why save small babies etc. So there are these lots of societal issues and there are policies. Is this free? Is there care? Is this a national program? All that is the outer setting. Unless you know that, it will be very hard for you to learn how to implement and where the barriers are. Some of the barriers may be in the outer setting. So you look at that outer setting and then you say, okay, what could be the barriers of this intervention in the outer setting? Then you go and look at the inner setting and you say, okay, what are the issues of facilities, healthcare staff, organization, culture of the organization, nurses, what do they think, doctors, what do they think, what do other people think, what does the health system, the way the facilities are structured, do they have any problem that will not allow kangaroo care to happen? So you look and analyze the inner setting. So it is to try to make a systematic foray into finding the problems, to find the problems in this and solutions, find the problems of inner setting and the solution. Then you look at what are mothers thinking, what are families thinking, what are other people thinking in terms of who get the intervention. And then you say, are there problems there? Do they need any solution? Can we solve some of those issues? And that only then you will scale up. Then you go to the process. And the process is that how do you engage the political community, health system, political, professional leaders, etc. So engagement of all the players, outer, inner, community, all these people need to have some engagement before you decide that I have this intervention. And then you make these some kind of a implementation model. And you may start with whatever is existing and you see what the problems are, and then you tweak it, and then you execute again, you evaluate, you reflect on it, and you opt. So that's the process. Next. So again, in terms of how do we organize a study like this? It is implementation research. So it must have implementers and it must have researchers. And it must be done in the setting where program is being implemented. If you are doing implementation research in an artificial environment, it is no longer in implementation research as far as I am concerned. It must be within the system. So I have taken an example of a public health program. It could well be a hospital-based thing where the implementer may not be Ministry of Health. It may be a group, a chain of hospitals. Here it's a public health program. So I've taken Ministry of Health and the research group. So the overall role of the Ministry of Health is to actually be the implementer. They are already the implementers. They should also implement the revised model, optimized model, etc. If you are going to fund the implementation or you are going to take over the implementation as a researcher, then there is no point in doing it, because then it will fail again when it goes to the implementer. Because the implementers must implement, not the research team. However, there is a part of research team that I am calling implementation support, but I'll come to that. But the primary responsibility of implementation is with the implementer, and the cost has to be borne by the implementer, not by the research project. Otherwise, the moment you withdraw, all that what you created will vanish. So we need to find the resources from within the implementer, most of it. Some things you can put in, some little injection of resource, which I talked. But the bigger part of this is decision making. Why decision making is actually the role of the implementer is that we shouldn't be implementing solutions that are not sustainable, that are not scalable, that are not possible within the resources that they have. Then we are not really helping. We are saying, yep, when you will get your budget of 500 crores instead of 5 crores, then it will be worth. Who has interest in that? Nobody has interest. So the decision making, these people are at the helm of decision making because we don't want to implement something which they are not convinced about, which they cannot argue to include in the program later. So it is a partnership. It is both are equal partners, the implementers and the researchers. In fact, I have gone to the extent to say always to the program, and I, as Secretary DHR, say that to the Secretary Health, that we are the support. We are basically doing this project for you, under your leadership. We are giving you, we are the supporters. We are not asking for your support to do research. You are wanting, if you don't want this project, then why should we do it? So we shouldn't do big implementation research projects unless we are able to convince the implementers that this is important to learn. And therefore, their role is critical. The team is all these program managers, policy makers, implementers. They are all part of the teams. They decide the initial and refined implementation models along with everybody else, and they implement. That is their role. What do then the research teams do? They provide support for implementation. So anything new, any new solution will require some injection of technical information, maybe a little bit of support on logistics, infrastructure, etc., training, monitoring. Because otherwise, if you have only the program to do it, how will they know what to do? How will they learn? So the research team has one role, which I have a team there, implementation support team. But this team cannot take over the function. It is a support. It is 100% implementation, 5% support. Not 5% implementers, 95% implementers. That is not the case. But then there are qualitative and quantitative research teams. What do they do? What the qualitative research teams do is they do formative research to develop the initial model. That what is wrong in this outer setting, inner setting, individuals, in the processes. What can we tweak? What can we change? What needs to change based on that understanding of formative research data? But we don't want 1 year of formative research to continue for years. Sometimes it continued for, I've seen projects with 2 years of formative research. We believe, I very strongly believe, formative research should be in weeks, not in years. Quickly to understand and develop a model, because what you will learn is by implementing, not just by asking. Unless we implement something, some change, it will be very difficult to find what we are doing. So continued program learning is what the second role of the formative research becomes. So they don't stop. They continue to collect qualitative data to refine the model and monitor the process as it is happening. The implementation support team, I said, is supporting the program to implement and also contributes to the model. All these people contribute to the model refining. The outcome measurement team collects quantitative data throughout the study. Now, why are these two teams important? I don't know how many of you are physicians or have studied physiology, but those who have, think about any human or animal, how they work. How do we work? We have some afferent nerves, right? We have senses. Some are general, like touch, pain, pressure, temperature. And the second are special senses, eyes, ears, sound, nose, through which we get special information. Now, if I only had feel, touch this, but no vision, I would probably not be able to survive. If this, as a group, if we had human beings had no vision at all, other people would have, killed us easily. We couldn't do. So there is a need for all these senses. I think about data as sensory information. Qualitative data is special senses. It is giving us special information. What do people think? Why is this not happening? For example, if you feel something is hot behind me, suddenly I feel something is really hot. I get a hot feeling. That is general sensation. But to know why is it hot, what would I have to do? What the first thing would be, what is it? Fire. Now I know why was I feeling hot. Right? Because I have used a special sense. I cannot use my nose, but I could smell smoke. Then also I would be alarmed. Yeah? I use all my senses. I could hear something crackling, which would be the. I use all my special senses to know why something is happening. Right? So formative research is similar. It answers the question why. Why are things happening? Why are they not happening? Because we do inquiry, qualitative inquiry. What do you think? Why did you not do this? Why were you not able to do this? Why were you able to do this? So it tells you why or why not. But the outcome measurement is like general feeling. It tells you what is happening. I'm feeling hot. There is something hot. So what is hot? So the what is collected by the quantitative data. So when we collect data on, let's say, coverage and quality and continuously measure it, it will tell us what is happening to coverage, what is happening to coverage and quality. Is it changing? Is it not changing? If changing, very good. My model is working. Continue to implement and refine little bit that model. Not changing, what I had thought probably is not right. I need to go back and think. But before that, I need to know why is it working? Why is it not working? So collectively, the quantitative data on coverage and quality and the qualitative data on why coverage is not changing or quality is poor and why quality and coverage is good will tell you both together information that our brain needs, right? So I've used all my senses now. There is fire, it's hot, I've seen, I've heard crackling, I've smelled smoke. Good. But if I don't do anything with that information, useless. But it goes to my brain. So brain is the central processing unit. And we are saying here the central processing unit is a combination of all these, chaired by the National Health Mission, for example. Now that brain takes all that information in and says, what should I do? First thing is run. See that fire behind me? I'll get burned. I should get up from this chair, just run. Right? So I make a decision in my mind, and that decision making is done as a combined unit of decision makers, which include the research team and the implementers and policy people. But then comes the effector arm. I cannot run if I don't use my muscles, my limbs, right? I have to stand. I have to use my gluteus maximus, minimus. I have to use my quads. I have to use my hamstrings. And then I have to walk and I have to run. All that is motor activity, which means effector arm, thing that does things. The doer is again going back is the implementer. It is those people who will implement the program, which will implement. So I see this exact same process in implementation research. You collect information and the research team gives that information to the implementer. The implementers and the research team decide, are we going in the right direction or not? You change, you go to another direction. And all these data have to be concurrent for us, immediate. But the approach must be systematic. As one model I showed you, the model of consolidated framework. And the government in this case, which is our major implementer, it could be all NGOs who are implementers. No problems. Implement. Who will implement in the future? Not an artificial implementer. That government का program को लेकिन आज मैं NGO use करता हूँ. I will use the NGO today. No, you do it like that. Next. So this is again something which I have drawn from what I think exactly to say what I have said so far. There is some current policy. There is always an existing implementation strategy, whether stated or not stated, whether written or unwritten. Something is being implemented. Nothing is starting from zero unless it's a completely new intervention. But something is happening and that policy leads to some implementation strategy. Usually it is based on expert consensus or it is simply based on that the Secretary Health will decide as a kar lo. It is done. But it is there. We are never starting without some zero model. And I call it model zero. Then you conduct formative research. In red are the activities of the research team. In dark blue are the activities of the implementers. In light blue is a combination where everybody will sit together and redesign. So that is the brain part, right, where the decision will be made. So that formative research will already lead to saying we must change something. If these people will never come to these facilities, we must have an alternative. So you will have a model 0+ that you will develop based on the formative research. And this model is developed by this government-led workshop. Because if you do it yourself and don't involve the decision makers, later they will not implement it. They will say कि हमें तो पता ही नहीं कैसे करना है, ये तो हो ही नहीं सकता. This cannot be done. So model 0+ you develop, you implement it for a period of time. While you are implementing, you provide implementation support. So within that also you will identify more problems, right? So you keep on solving small implementation issues. But evaluation or quantitative team will concurrently do safety, coverage, impact, whatever data, quality, whatever data you want to collect. But it is very important, later I'll tell you, that you must decide that outcome that can change quickly. If the outcome is not going to change in that period of 6 months, then it is useless for you, because then you cannot decide on that basis. So you choose only those outcomes which can quickly change. If something requires 5 years to change, not a great outcome for implementation research, because you will not be able to, or at least developing the solutions, not a great idea. So you want those outcomes. So when I talk about outcome that I want to measure, I use it as my North Star, ध्रुव तारा, डायरेक्शन, मुझे कहाँ जाना है ये फिक्स कर देता हूँ. उसको मैं कहता हूँ कि मुझे कवरेज 80% लोगों का चाहिए. कि मैंने जब when I did the KMC study, when we planned this, so we said the goal is of all children who are low birth weight, who should be given kangaroo care, at least 80% should get kangaroo care, and the quality is not for 1 minute, for at least 8 hours a day. So we said we will measure as our North Star proportion of low birth weight babies who are getting kangaroo care for at least 8 skin to skin contact with the mother and exclusive breastfeeding for at least 8 hours. And if that is not changing, then my model is not working. If in 6 months I could not change that, then what is the use of my model? I should get more and more children who are born in these 6 months to new children who are born to get this intervention. Okay? So fixing that evaluation point, you cannot measure and optimize 105 outcomes, and even 6 outcomes at one point. Try to optimize 5 things together: pleasing your husband or wife, pleasing your child at the same time, pleasing your parents at the same time, and pleasing all your neighbors at the same time, and also all their relatives. I want to please all of them. Try it out. It will not work. But if you say, I want my immediate family to be happy, 3 people, and something that is good for both my parents and my spouse and my children, you are optimizing 2 or 3 parameters. You cannot optimize 15 parameters at the same time. You can never do that. So optimizing evaluation parameter should be 1 or 2, not 10 or 15. Because otherwise you don't know, are you going, this one you are getting, but that one you are not getting. So should I go here or should I not? Should I continue or should I not continue? I will only be able to learn that if I know that my North Star is fixed. I'm going north or not going north. Period. Right? I'm going in the right direction or I'm not. And you cannot say I'm going north, but I'm also going south, but I also want to go west, and I also want to go east. Where will you go? आप कहिए north and a little bit east. I want to go between them. Okay, you can still optimize. But if you want to go in 4 directions at one time, essentially you are going in no direction. Program learning team is the why, the afferent nerves, the sensory nerves of special sensory. and the evaluation is general sense review. Implementation support is the effector. It is helping in the effector. It is helping the implementers to implement. Once you've done that, then you regroup and say, what does my data look like? I have improved, I have not improved. You consider all these data, implementation support data, program learning data, evaluation data. You got all the feedback, and then you develop the next model and say, I will change these 3 things, but I'll keep the others, but this one completely useless. I'll drop one, add 2. You decide as a group, and then becomes model 1, then becomes model 2. You, as much time as you have, you will keep on trying until you achieve your closest to the North Star. Sometimes you will not reach that goal. Some people said, how will we reach 80%? I said, you try. Maybe you will reach 70, maybe you will reach 75, but you keep trying until you have time. Then they asked me a question, but how can we get population-based coverage? How many? We don't even know who are low birth weight. I said, so how will you be effective? If I only go to a hospital where I measure birth weight, how will it create impact? How will it create coverage in the population? I want all low birth weights to get kangaroo care. They said, does it mean we have to now improve, measure birth weight of everybody? Of course you have to. That is where you then start getting into the trouble. That, okay, my biggest problem is I don't even know who's low birth. If I don't know who is low birth weight, I'm missing. How will I give intervention? I said, of course. Okay. Yeah. We have to do that. Yes, you have to do that. If you want to achieve high coverage. Then the next question. But we can do it in hospitals. But what will we do for those children who are not in hospitals? Do you think? How will you bring them into the fold? Either you have to have a strategy of home-based KMC, or you have to have a strategy of bringing those people to a facility and they are unwilling, maybe outpatient facility, train them, go back. God knows what you will do. I don't know. But you cannot achieve high coverage only for those who have come to you. So having this type of goal will define what are the real implementation issues. Otherwise, we would have said, hospital mein ye kar lo, do this, do that. We would have missed 50% of the key issues, which are actually blockers of implementation. Yeah. So I conclude that implementation research addresses the question, how to scale up and achieve high intervention coverage and quality. When we do other types of research, usually our question is starting with what? What is the effect of A on mortality? What is the effect of B on this? So we usually use, if you are starting your, this is my guide to myself. If my question starts with what, I don't consider it an implementation research question. I try to start my question with how. How do I scale up? How do I achieve high intervention coverage? How do I do this? Then my question is correct. And have you ever seen the answer of a question that starts with how, the answer being 45%? If I ask you, how do you go to the airport? Can you answer 35 kilometers or 15 kilometers? Can you answer 45 minutes? You cannot. Usually when I ask what, you can answer. So if I say, what is the distance between ICMR and the airport? You will give a quantitative number. So never ever is it possible to give an answer to how by saying that we achieved 25% or 30% or 40% coverage. That is not the answer to the how question, because then you are not answering the question. So if I ask you, how do you go to the airport? Your answer has to be, okay, if you need to go to the airport, you can walk. But when you walk, it will take you 4 hours. And you should have the ability of an athlete, because it is 15 kilometers walking. Not everybody can do that. So it will tell the cost, will tell the ability, you will tell the time taken, and you will say you can walk. However, if you have to catch a flight in the next 3 hours, you have an option of calling an Uber or a Ola or whatever, and sit in, keep 45 minutes, have 400 rupees. Yeah, that is the how. How will I reach? You will call an Uber, but I cannot say, वो कहेगा बाद में आपने तो मुझे Uber बुलाया, मेरे पास तो 85 रुपए थे. Then you will say, however, if you want to reach in 50 rupees, there is also a metro. You go from here, you walk to the metro station at Ames, go downstairs, you take the metro line X, whatever color, then you go to Connaught Place, and in Connaught Place, there is a Rajiv Chowk station. You change the metro, you go directly to the airport. You can reach in 50 rupees. But it will require not 45 minutes, it will require 1 hour, 1.5 hours, whatever. Right? Whatever, the how answer has to be, how do you do it? It cannot be the answering, it is feasible. So if I ask you, how do I go to the airport? You say it is feasible. Does it help? No. Right? Similarly, when we say we have done implementation research and our conclusion is it is feasible to deliver a hypertension program. So what? I want to know how. You are telling me it is feasible. Or you are telling me we achieved, yes, the result is 40% people were under control. Yeah, that is a kind of an interim result. That previously only 10% people were under control hypertension, now 40% are. And now I am telling you, how did I achieve from 10 to 40? But 40% cannot be the answer to my research question. Very important. Research should be guided by program people, by program managers, policy makers, implementers. It optimizes the implementation model, which is scalable, because once it is done in consultation, it is more likely to be scalable than something that you yourself are thinking that I will do this. Somebody told me, I got a proposal on IR last year, which wanted to get a third A&M only for NCD. And I was saying, how they will get it, but have they actually consulted with any program? प्रोग्राम में इतनी मुश्किल से तो CHO को लगाया इस काम पे, अब वो तीसरी A&M क्यों लगाएगा? दूसरी नहीं आई है अभी सभी जगह. So either consult with somebody, no, don't give flight of ideas. ऐसे हो जाएगा. You have to talk to people to say, is it feasible? So outputs are, programs can use that output to implement it. So that is kind of a broad overview. I didn't go into too much of a single project, but thank you for listening, for those of you who are still there. And if there are any questions, we would be happy to answer in the chat box if you want to write. Or if the time is over.
would have been benefited. There are 318 participants still online, and around 400 are watching the YouTube live sessions. So around 700 participants are there. We have allowed them to give the questions on the chat box, and here are the few questions. I will just read it out aloud.
Yeah, take the
We have taken the
few questions.
Yes, sir.
And then later, if you want, you can discuss with me. We can put them on some kind
Yes,
of
frequently asked questions. The first question is implementation science research only understanding and addressing the barriers? If yes, what is the actual implementation of the proven intervention at a large scale called?
So say that again. What is the last part? What is?
If yes, what is the actual implementation of the proven intervention at a large scale called?
It's called a program. That is the meaning of a program. So once you learn how to implement better and you give people, when they scale it up, it is not research anymore. It is implementation of a program at scale. So any program is being implemented, but it is not reaching what it wants to reach. It is not reaching the scale or not reaching the coverage. It has breadth but no depth. Sometimes it has depth but no breadth. And once we have done some implementation research, hopefully it will help the program to actually implement the program at scale.
Next is, what is the difference between implementation research and system thinking?
Yeah, so systems thinking is thinking, systematically thinking. Conducting a research study requires systems thinking, systems approach. Usually systems thinking is related to health systems, which include all the elements of the health system. And there is a whole book, a document, I think, on systems thinking by Alliance for Health Policy and Systems Research. These are concepts. When I think of implementation research, I think of an actual study with a research question, methodology, conduct, results. Systems thinking is an approach, how to think systematically, but also across all the health system.
Would the MRC complex interventions framework be applicable for effectiveness research, IR, or both?
All frameworks are acceptable. The point is, all are wrong. So there is a very nice saying by somebody that all models are wrong. Some are useful. So I am not saying CFIR is the only model. I don't know the details of the MRC model of this, but all models have some good things and some bad things. You need to use them in a way that you think would be the most beneficial and should be able to justify. I don't think, but having some framework or something to hang everything, otherwise you may look at one area and forget the other. That is how I use frameworks. None of these frameworks are perfect. All are good. Some are more useful than others. And I just told you this. I use that because I find it useful. ठीक है, ये भी सोच लिया, ये भी सोच लिया, ये भी सोच लिया, ये भी कर लिया. कई लोग रीएम फ्रेमवर्क यूज करते हैं, कई लोग कोई और फ्रेमवर्क यूज करते हैं. उससे इस चक्रों में मत पड़ो. उसमें कोई I do not think of, see, after you learn a lot of methods, then you will learn that all the methods eventually are all have, there is an element of incorrectness in everything. And when you go above that, you are able to see that there are some common things in methods and there are some different things. Whatever suits your project, whatever suits your imagination, what helps you to do things better, use that. Who is saying that CFIR is the only framework in the world? I don't think so. In fact, when I started, I didn't use any frame. But then there are two problems. Sometimes you forget something. Second problem is that you cannot publish because they will ask you academically questions. What did you use? So it is always good to decide, look at all that are available, see what fits best your question, your problem. Whatever is helping you solve your problem, use that. Is the next question.
It resembles participatory action research.
Sorry?
IR resembles participatory action research for a problem in context systems where actors are program staff and the research team are facilitators.
So I will say only one thing. I have learned and taught epidemiology, statistics, research methods on surveys, cohort studies, implementation research, clinical trials, community randomized trials, step-based design, all of them. But one thing I have learned is we confuse ourselves with words. Don't go by what words I use. Go by what I mean. It does not really matter unless there are absolutely clear definitions that you have to say, somebody said it resembles PDSA cycles. Yeah, sure, it may. But conceptually, what is it that you are trying to do? You are trying to find the problems, you're trying to find solutions, you're testing the solution, and then you are seeing it is scalable, and you actually put it to scale and test is scalable. So if you are able to do that, I care two hoods. You call it participatory action research, call it implementation research. You can call it whatever you feel like. Truly speaking, it does not matter. You call it shot a helicopter shot, or you call it Dhoni shot, or you call it whatever. What difference will it make to the 6 runs that it gets? We are all worried about naming, renaming. We have to understand that implementation science is probably very new. It is very nascent. At this moment, everybody is putting their own terminology on many things. At one point in time, it will get a little more fixed. Like now you cannot say what is sensitivity definition is something else specific. Here, give yourselves a little leeway. Be a little more relaxed when you listen to people. And you also say some things. Do not take it like we know everything about implementation science. In fact, I would say implementation science today is where cluster randomized trials were 30 years ago and where randomized control trials were 70 years ago. There is maturation of some things will be standing the test of time. They will be called something or not called something. And then you can go into the act, what is it? As long as you are doing what is supposed to be done, you're fine. So don't go by too much of this. It is too nascent at this moment.
IR is about the process and challenges in implementing the intervention at scale. How big should that scale be? In other words, how do we arrive at a number of study units?
Good question. One is what should be a study unit? Now, ICMR has started a large number of implementation research studies So when we have given it a great deal of thought, so for me, the ideal unit, single unit, is a district. Why? Several reasons. It is probably the smallest self-standing, completely, which has its own leadership program. It's a full administrative unit, a full health unit. It has structure also like that. At the apex, there is a hospital, district hospital. Then there is now every district in India will have a medical school, hospital, medical college hospital. Then there are sub-district. There is so ideally, if it is possible, the district to me is a good unit as one unit to have. And we've tried this all across the world. Even if districts are small, they are quite independent in many ways. And there is not much contamination, and there is learning at a systemic level. The second thing is how many districts. And that's where the context becomes important, that you cannot do it in all contexts. So we took a practical decision in ICMR that we'll try to cover at least one district in each of the 6 regions: north, south, west, center, east, northeast. And having these 6, 7 districts or 8 districts, if we take some of those. So most of our studies are between 6 and 8 districts. And that number 7 has another thought in terms of scale. It is 1% of India. We have about 740, 45 districts. That's huge. That's scale. That's huge scale. But many times we found that it may not be possible with the resources we have to implement at the entire district. In that case, it is equally possible that you implement in the district, because implementation is to be done by the district. You don't need to invest a lot of money. Largely, your money will be spent on collection of data. So there you can sub-select a few blocks, for example, and say that we will get data from a few blocks, but the implementing unit is still a district. This is a strategy that we have used to save research resources. But that is the kind of scale I am talking about. I'm talking about multi-district, multi-state or regional program. Now, one of our projects, Accelerated End of TB, is one district in every state. That is the epitome, but we are struggling. 38 districts. How much resources can we provide? Now, the program wants it like that. We are trying to do that, but it is very difficult to reach that level of scale.
I'm skipping some of the questions. Coming to the last question, what message do you have for clinical researchers keen to pursue IR? What fundamental shifts one should have as a characteristic?
Fundamental shift. So I have probably done most of my life. I have done clinical research, interventions research has been my forte. Although I've done cohort studies, I've done qualitative studies, I've done all kinds of research, cost effectiveness, costing. But if I see 2/3 of what I've done is probably interventions, evaluating interventions. And it takes a while for you to change the mindset, because you always think about doing the same thing. I have a fixed intervention. Usually when you are doing clinical trials or intervention studies, you have a fixed intervention in mind. You develop it a little bit in the beginning, then you fix it. And what is the variable? The variable is the final outcome. That what is your outcome? In this case, what is completely not fixed, actually absolutely unfixed, is what the intervention model will look like, because it will depend upon the problems, it will depend upon the solutions, it will depend upon the solutions that work, and you have to weed out the solutions that don't work, even if in your mind that was the best solution. Because in a trial mode, we go by our idea and we evaluate that idea. Good or bad outcome, whatever the result may be, we say this is the result. But in this case, that is not. You go and you look at what is fixed is I must reach 80% coverage or 70% coverage. That is fixed. That goalpost is fixed. What is variable is how I will reach there. And that will be my result. Always the variable is the result, not the fixed. So that change of that mindset is critical. The second thing is intervention researchers or clinical researchers or trialists often want to add impact outcomes to implementation research. Not a bad idea, but makes it much harder. But don't change your mindset. The mindset has to be, so for instance, I like saying this, that when I was talking to Bill Gates once, and he was saying, what is it that you are doing? And why this implementation? Will it actually, I said, that we will achieve 80% coverage of KMC is a guarantee. The only thing I don't know is how much money will it cost? How many people will it require? Can I do it with the people that are already available in the money that is already available, or what is the extra? And what we don't know is what rules of the game we will have to change. What are the policies that will require to be changed? That's all. So if you can have that different mindset, then you can do good implementation research. If your mindset is always that I have an idea, I want to implement that idea, and whether or not it succeeds, then you are basically doing a trial. And that is not a bad idea, but then it will only test whether it works or it doesn't. So thank you very much for all who are still here. I know it's late in the day. Thanks for listening. Bye.
Thank you so much. Thank you, sir, for very detailed, elaborate, and answering all the questions pertinent which were relevant. I look forward for the next session on 21st of August, same time, and I expect a similar kind of a participation and response from that end. Thank you so much.